Somebody is screen sharing. I'm sorry, let me just go ahead and share my video.
Hello, everyone. My name is Dr. Abiola Fashina. I'm the Medical Director and CEO of Emergency Healthcare Consultants. We're very excited to launch this streaming online platform with TuneIn to host emergency and critical care content for education that people can access to learn at their own pace. A little bit of a background about Emergency Healthcare Consultants. We are a firm located in Lagos, Nigeria, so we're proudly Nigerian. And we're focused on emergency and critical care education with a particular interest in practical hands-on.
Sorry, Dr. Fashino.
Yes.
Simulation.
Okay. You were muted before.
Lastly, we've just launched
Can you hear the
Point of Care
lecture?
Ultrasound Academy with the partnership of JNCI and GE, where we are offering courses in point of care ultrasound across a gamut of modalities, including echo, lung, musculoskeletal, procedural guidance, and ocular ultrasound, just to name a few. So in that, after that quick introduction, let me just go right into the course. Today, we're going to be talking about the basics of oxygen administration and ABG interpretation. So to review the objectives, we are hoping today to cover the following things. We're going to be discussing hypoxia, indications for oxygen therapy, various delivery modes that are available, the hazards of oxygen therapy, arterial blood gas analysis, including a review of normal values, a stepwise algorithm for interpretation, and then we'll have a few example ABGs to practice with the method that I am going to show you today. Let's go ahead and get right into the course. So first things first, we need to do a bit of a review about terminology. We have a lot of different ways of describing low oxygen states. There is hypoxia versus hypoxemia. And it's important to know the difference so that when we are speaking, we are using the right term and speaking with one voice. Hypoxemia refers to decreased arterial oxygen or partial oxygen tension in the blood. It is a laboratory value that needs to be measured. And the normal value usually rests somewhere between 80 to 100 millimeter mercury. Hypoxia actually refers to reduced oxygen supply at the tissue level. And it is not something that's measured by a lab value. It's something that we get clinically from the bedside, from our examination, from our clinical exam, from the patient's symptoms, from the signs we elicit. And so we tend to think of the value in the ABG when it is low on the PO2, hypoxemia, but your patient is actually hypoxic. So that's just a quick digression to address the difference between those two terms. Look about the fraction of oxygen in inspired air. Room air, what you and I are breathing right now because we're not in distress, is 21% or 0.21. And then as you go through from 1 liter, you add 4% to 20. And so at 1 liter, you have 24% FiO2, 2 liters, 28% FiO2, 3 liters, 32% FiO2, and on and on. And so there's actually a very easy way to calculate out the fraction of inspired oxygen that you're given for your oxygen delivery device. And this is very important because we want to make sure that we are understanding the amount of oxygen we're giving. We are going to think of oxygen as a drug. It's a dose response. We are giving a certain dose. We need to think about the duration. We need to think about the frequency. And we also need to think about a titration and weaning off strategy. And in order to understand and do that, we need to know the amount of oxygen that we're giving. So oxygen therapy refers to the administration of oxygen at concentrations that are greater than anemia or 21%. Once you start to give supplemental oxygen, you are then administering oxygen therapy. And once again, I can't emphasize this enough. We have to treat oxygen as a drug. So there are actually 4 different types of hypoxia. And it's useful to review them because I think it's always very important to ensure that we go over the pathophysiology behind what we are discussing. A clear understanding of pathophysiology is usually helpful to help clinicians better understand the clinical management of whatever it is they're seeing. So if we review the 4 types of hypoxia, and remember that hypoxia is decreased tissue availability of oxygen. It's a clinical thing. We have hypoxic hypoxia. So in this case, the patient has a normal oxygen carrying capacity, but for whatever reason, there's decreased oxygen tension in the blood, leading to varying degrees of hemoglobin desaturation. What do we mean by this? The patient physiologically has nothing wrong, but there's just less oxygen in the atmosphere to pull. A great example of this would be high altitude. When you're climbing a mountain, we say the air is thin up there. What we really mean is that there isn't as much oxygen that high up as we see at sea level. And so it becomes harder to breathe. And if you're not acclimatized to those sorts of environments, you really can get some significant hypoxia. Another example where we might say hypoxic hypoxemia is in patients who have cardiac shunts, where due to defects in the cardiac circulation, they might actually not be able to fully oxygenate their blood in the right way. And so even though their hemoglobin carrying capacity is fine and they have enough volume on their blood, they're just not carrying as much oxygen in that blood due to a cardiac shunt. The last example of this that we might see would be diffusion defects from something like pneumonia. Remember that oxygenation happens at the interface in the lungs. If you have a pneumonia, which is sort of hindering the capacity of the blood to be adequately oxygenated, then you have wasted ventilation. And so the blood is going there, but it's not being adequately oxygenated. And so then by the time it's circulating through the system, you're not carrying enough. The patient might actually have good hemoglobin and have great capacity to carry oxygen, but just doesn't have enough oxygen to go around. So those are some examples of the hypoxic type of hypoxemia. The next type that we'll discuss is anemia, which is almost the opposite of what we just discussed. In this case, there actually is a decrease in your oxygen carrying capacity because there is a decrease in your functional hemoglobin. Please take note of the term functional hemoglobin, meaning that you can have this happen, of course, because you have significant anemia from chronic disease, but you also know that hemoglobins can be poisoned, for instance, from carbon monoxide poisoning. And so you might actually have normal hemoglobin, but functionally your hemoglobin is decreased because some of them have been poisoned by carbon monoxide. And so this is an example of anemic hypoxia, which is another type of hypoxia that we may see. The third type of hypoxia is the stagnant type. In this case, the oxygen carrying capacity is fine. The oxygen tension is just okay, but there are problems in the circulation. I think of this as a block in the pipe. It's kind of what your plumber has to do when they come and clear your drains. The pipes have something there that is impeding the flow of blood and therefore impeding the delivery of oxygen to tissues. Examples of this are low cardiac output states, vascular occlusions that return the blood. We're talking about distributive shock and sepsis, where because of the immense vasodilation, everything is just stagnating and not moving. Hypovolemia, you just don't have enough blood to go around. Or pericardial tamponade, where the physical obstruction around the heart actually impedes oxygenation of the blood, but also impedes circulation of the blood around the system. The very last hypoxia that we will discuss is the histotoxic. And to a certain extent, there's an overlap between the anemic and the histotoxic. In this case, the oxygen supply is just fine, but the tissue utilization is the problem. And a good example of this is cyanide poisoning. In cyanide, where usually your oxygen is just fine, but because cyanide has such an affinity for our hemoglobin, it impedes your ability to actually use the oxygen that's available because now it poisons your hemoglobin. And so these are the examples of hypoxia that we have. And it's very nice sometimes to sort of categorize in your head what you're dealing with when you see the patient. And of course, this takes just a second or two. We're not going to sit there for 10 minutes and be thinking, what kind of hypoxia is this? But it's just important to realize what you're dealing with and tailor the therapy to the right problem. So clinical goals of oxygen therapy. This is where we're using the information we just learned. So you're giving oxygen therapy for a few reasons. You're doing it to decrease the work of breathing. We're using it obviously to treat hypoxia, and we're also using it to decrease myocardial work. For instance, this is a very classic example of why oxygen in heart attacks. Now you have cells that are necrosed and myocardial necrosis happening, and your heart is working really hard to try to keep things going. And as it's working harder, it's actually exacerbating the process of ischemia. An effort to offload that stress on the heart. You give some oxygen just to decrease the amount of work it's doing while you figure out definitive therapy. Looking to the table on the right, we see now the types of hypoxia. So we see the hypoxic hypoxia responds really well to oxygen therapy. It's of optimum superior benefit. So that means when you're at high altitude, when you have cardiac shock, when you have these pneumonias that are causing diffusion effects, it's really good to give people oxygen in those settings. In anemic hypoxia and stagnant hypoxia, oxygen might also be beneficial, though maybe not so much. In anemic hypoxia, for instance, if you've just got hemoglobin that is poisoned, or you just don't have enough of it, while supplemental oxygen would be helpful, it's certainly not going to get to the root of the problem, which is that this person needs more hemoglobin. But you might want to be doing there actually something like a blood transfusion. Or if it's carbon monoxide, that's kind of a unique case where you give oxygen and give it actually at very high flow, if possible, barrier oxygen, because you really want to just have carbon dioxide, carbon monoxide system. Stagnant hypoxia is another one where oxygen might be helpful, but it's not a definitive answer. You can imagine a good example is pericardial tamponade. You have to buy a few seconds with supplemental oxygen, but if you don't do a pericardiocentesis, you're not getting anywhere. And then in the histotoxic hypoxia, it doesn't even really help at all. Cyanide poisoning, we have a cyanide kit that we have to use to kind of actually reverse the poisoning. And you can get all the oxygen that you want at that point. You will see no benefits until you do something about that cyanide toxicity that has poisoned your hemoglobin. And so this is just a very good way to think about why you are giving oxygen. It's not just, and we should always think about this whenever we are giving oxygen as therapy, because we are thinking of it as a drug. Same way we think of any drug we're going to administer or give at any time. Of course, when you want to assess the need for oxygen, if it is available, the ways that we typically do this is with pulse oximeter, or even better, we do it with an arterial blood gas.
Thank you, sir.
So what are some of the indications for oxygen therapy? Well, we've talked about hypoxia. The PaO2 comes down below 60. We've talked about a normoxic hypoxia, low cardiac output, anemia, carbon monoxide poisoning, where supplemental oxygen is needed. Trapped gases, obstruction, and pneumocephalus are reasons to also make sure that we are giving supplemental oxygen. And then special situations like anesthesia, where actually we are ourselves as physicians or clinicians inducing a state where a person is not able to take in as much oxygen themselves. We are decreasing their respiratory drive with paralytics and sedatives. And so in cases like that, we need to actually give oxygen to supplement what they cannot do themselves, because we are taking over that drive or we're diminishing it in some way. So let's talk a little bit about the modes of delivery. There are essentially two types. We have the low flow or variable performance systems. And then we have the high flow systems. In the low flow systems, essentially what you are seeing is a system where you are contributing to what the patient is already able to do, which is essentially why our low flow systems are not appropriate when we have severely obtunded patients who are really altered and really have completely lost their respiratory drive. So these are contributing partially to the inspired oxygen the patients breathe. And examples of this would be nasal cannula, a simple mask, non-rebreather mask, partial rebreather masks. Those are all in this low flow or variable performance system. They are giving a variable amount of oxygen that really depends on the patient's respiratory rate, the patient's respiratory drive, respiratory physiology, and dynamics. All of these things impact the ability of the patient to extract oxygen from these systems. Then we have the high flow or fixed performance systems. These are delivering specific and constant percentages of oxygen independent of all of those factors I just mentioned. Good examples of this are Venturi masks, tracheostomies, whether you're using a TP, so a trach collar, non-invasive ventilation systems where you're setting a particular PEEP, you're setting a particular FiO2, CPAP, BiPAP, you're delivering oxygen at a fixed rate each time. In pediatrics, we're thinking O2 hoods and tents, and home concentrators are also actually in this category. So we're going to go through some of the examples in each category, just to talk through the different modes of delivery. I tried to pick the ones that we see the most in hospitals, because I think a lot of us just grab an oxygen delivery device, and maybe we don't actually really know the background to what we are using and how it works. So the most common ones see the nasal cannula or nasal prongs, as they are called in some parts. It's usually 18 to 14 gauge tubing with the nasal prongs attached. These are the nasal prongs here. And the reservoir of oxygen is delivered to the pharynx through the nose and builds up in the pharynx and then sort of trickles down. I have heard some very asinine comments. People will tell me intranasal oxygen giving 100% oxygen because they dialed it up to 15. Actually, this can only give 24 to 44% oxygen max at your flow rate of 1 to 6 liters per minute. You really can't do more than that. You can dial it up to 15, dial it up to 12. You're pretty much maxed at 44, 45% on a nasal cannula, if this is what you're using. And of course, it's influenced by breath rate and the physiology of the lungs because it is a low flow system. So when you are using a nasal cannula, this is really one that you have to use when the patients are able to also do some of the work. This is not appropriate in a code. This is not appropriate in a person who has massive intracerebral hemorrhage or intracerebral stroke or issues with possible damage to the respiratory drive and respiratory center, people who are superiorly obtunded. You cannot use a nasal cannula for those folks. It's just inappropriate. Another example of another low flow system is the simple oxygen mask. This is what I'm showing you here. This area here usually connects to some tubing to your cylinder. It has exhalation ports on the sides of the mask here that you can see. The flow rates on this go anywhere from about 5 to 10 liters maximum. Actually, when you're using a simple oxygen mask, you really need to make sure that you have your flow rate dialed up at least to 5. Otherwise, you don't wash out the CO2 in the mask. And so the patient is basically just breathing and circulating CO2 instead of putting in new oxygen. Depending on how they breathe, you can give about 40 to 60% FiO2 using a mask. So this is going up from the nasocannula system, where our maximum was about 44%. The next system that we're going to talk about here is the partial rebreather mask. The partial rebreather mask actually looks completely the same as the non-rebreather mask, but there's a couple of differences in the mechanics of this mask. So we'll see here that it has these exhalation ports as well. But the partial rebreather mask actually has doesn't have the one-way valve that we see with the non-rebreather mask. It can give an FiO2 of about 50 to 70% once you get the flow rates up to 8 to 10 liters per minute. So we've gone up from the oxygen masks, which we said would give you about 60 maybe max. You need to make sure the bag is at least a third full during inspiration. So I'll see people who will put these masks on and that reservoir bag. This is the reservoir bag, it's just empty. It actually needs to be full because what's happening is the patient is pulling oxygen from the reservoir bag. So if the reservoir bag is not at least a third to 2/3 full, the patient is essentially just pulling nothing. So you actually have to make sure you fill the reservoir as you put the mask on. And I typically just put my finger right there here, block off this entry point and let the reservoir fill a little bit before I put the mask on. This is a partial rebreather because, number one, when the patient exhales, part of that CO2 and all of those exhaled gases actually go into this reservoir. And then the patient is also pulling oxygen. So the reservoir actually has a mixture of exhaled gases and oxygen. And a little bit of the patient's dead space ventilation is actually also going into that reservoir bag. So the air and the oxygen is not flowing in a one-way fashion from the reservoir to the patient out. There's a little bit of an admixture going on with the partial rebreather so that things are mixing within the system. And that is why it's not able to deliver more than 70% FiO2 with the best respiratory dynamics. Sometimes if the oxygen is not coming from the reservoir because there isn't a lot, these exhalation ports, the patient can also pull oxygen from there because remember, there isn't a valve to control one-way flow of oxygen through with the partial rebreather mask. Again, there are limitations to this. Of course, it can be uncomfortable, it can be drying. Patients can't keep them on for long. They can't talk with them. They can't eat with them. It's not appropriate if a person is vomiting because then you increase the risk of aspiration. So you have to suction first. So you need to think about all of those things as you select this to decide if this is actually the best system for you. The next one we're going to talk about is the non-rebreather mask. And as you can see, the non-rebreather mask looks almost the same as my partial rebreather right here. The difference is a little bit of the way it's built. So the non-rebreather, like the partial rebreather, actually has two one-way valves. There's one here, and there's one here at the exhalation port. And what that does is actually ensures that there's a one-way flow of oxygen. So when you're using the non-rebreather, you actually have to turn the flow rate up to at least 12 because this reservoir bag has to be completely full. If you're using a non-rebreather and the oxygen bag is empty, you are wasting your time. You need to make sure this reservoir bag is full. And what I usually do is I just close that one-way valve there. I literally put my finger there and I let the bag fill up. Because of the two one-way valves, the oxygen is only going in one direction from the reservoir bag up. The patient inhales it here, and when they exhale, it cannot go back down into the reservoir bag, unlike the non-rebreather. Instead, it goes out through the exhalation ports, which also have a one-way valve so that that exhaled air cannot go back in. So unlike the partial rebreather, where there is an admixture of carbon dioxide and oxygen. In the non-rebreather mask system, we just have oxygen alone being drawn in and the exhaled gas going out. That's why the non-rebreather mask provides the highest concentration oxygen for a low flow system. We can get up to 95 to 100% oxygen. But again, depends on you turning the flow rate to 12 to 15 liters. You put a patient in a non-rebreather, you put them at 6, you're not doing
called that
anything.
myself.
When you're using a non-rebreather, you've got to dial.
I called that myself last week.
And that reservoir bag has to be fully inflated during use for it to be of any value. The same comes as a partial non-rebreather apply, meaning that, it's uncomfortable, the patients can't keep it off for long. You can't really use it if a person is vomiting, they have to be suctioned first. They do need to have some sort of mental status that is still there because they need to draw the oxygen into the reservoir bag. So again, this is not appropriate really in a code. It's not really appropriate for people who have major intracerebral damage, where they might have had some damage to the respiratory centers. You really need to consider another option. We're going to shift gears to the flow systems. And I'm only going to talk about a few of them. But remember that this is the systems that this category of system include our non-invasive systems. They include our ventilators, whatever device you're using to deliver air from that ventilator. But I'm just going to go through a few. So this is a Venturi mask. And the Venturi masks are very clever. They usually look like this. They have this tubing here. And this here is the jet adapter. So what the Venturi mask does is, as you pull in the air, it actually mixes the oxygen with some air. And then it delivers a set concentration depending on the jet adapter you select. So here you see all the different colors, and you put the jet adapter here. And depending on the jet adapter, you can actually determine the FiO2 that you're delivering. And it is very exact. You can deliver from 24 to 44%. And it doesn't matter about how the patient's respiratory dynamics or physiology is going. Once you select the jet adapter, the Venturi mask is delivering that oxygen to the patient at that rate each breath. It's a very precise delivery system. Doesn't dry the mucous membranes, which is a very nice advantage to this, but it has the same downsides as other masks, meaning it can be uncomfortable, patients can't eat, they really can't talk, if they're vomiting, it may not be the best option. You really need to think about all of those things if you're going to use a Venturi mask. I wanted to review trach collars. This is somebody who maybe has been intubated and now we're thinking through long-term oxygen therapy. They now have a tracheostomy and we're now putting them on the trach collar because we're realizing that they're going to be on the ventilator for a while. So we've extubated them and converted them to a trach. So this is for people who have a chronic oxygen requirement. We are bypassing all of the stuff in the oropharynx. It's more comfortable, it's efficient. If you're going to use a flow meter, you can go 8 to 10 liters per minute, or you can just hook it up to a vent if you need to. And it's just really nice. And this is a good way to use a weaning protocol before you put on a T-piece. If you have, before you put the person on just a collar, this can actually just be there as well. You don't have to hook it up to anything. For patients who have been weaned to the level where they really need some supplemental, but you're still watching them to make sure they don't regress back to a need for high supplemental oxygen. So these are some of the ways you can deliver these very directed, very fixed FiO2s per breath for a patient.
Yes, but I told you that we are going to do it. So why would you say we don't have?
We're going now on to
I told you they are finalizing the contract. And so we're going to look you in with the lawyer. Talk about this because I've explained that we need to think of oxygen as a drug. And so what are the downsides to oxygen? Everybody might think, oh, it's the atmosphere, we're breathing it in already. So what could the harm be in giving oxygen if the person needs it? Like everything else, too much is bad. So it's okay. They've done it now.
High concentrations of oxygen can actually cause a spectrum of lung injury. We're talking from tracheobronchitis or
Jackson and
diffuse
Tianedu,
alveolar
they're very
damage or
skilled.
death.
It's a very
And
reputable
clearly,
law
of
firm.
course,
They do a lot of
patients who
medical
have
cases.
a high
And they've
high
investigated a lot
risk
of these
this
very
are those
successfully.
who are on
So
mechanical
we'll get their
ventilation,
lawyer
who are
who's going to
particularly
take
on really
the
high
point on the
oxygen
case
concentrations
to
of
start
0.6
speaking
or
with you and
60%, and who are on this for prolonged period.
The 150,000
So
that
by
you
the
paid
time you
so
have,
far,
for example,
has
a
that been
person
refunded to
who's
you?
done 100% FiO2, we begin to
And
see
then what about
evidence
the
of
report that you
toxicity
got
within
from
24 hours.
NBC?
So that's how
I'd like to
quickly
share that
we're
so the
beginning
lawyers
to
can
damage
get
at the
that.
lung tissue, at the level of
Please
the
email
lung.
it to me.
And when we have patients
Dr.
with really
Ladipo, I
high
think, was
oxygen,
handling
which
the
is really why it's
investment.
important for us
Let me
to
find out from
think
him
about
what's
a
going on.
weaning strategy,
Do you have a
and
receipt
to also
for it?
ensure that we are not using more oxygen than we have
Can
to
you also
for the
email
needs
that
of
to
the
me?
patient at the time, because like everything, it has
Thank
a
you very much,
downside.
Dr. DK.
So the
All right, let me
cellular
get to work
injury,
trying to get the
oxygen
lawyers
itself
up
produces
to speed.
these increased reactive oxygen intermediates. We're talking about things like hydrogen peroxide, superoxide anion, hydroxyl radical. They can impair cell function, they result in cell death, and they can actually promote a deleterious inflammatory response, which itself, from the revved up inflammatory system, can lead to a secondary tissue damage and eventually apoptosis. Once you start to have all of these processes in place, then you have an increase in mucus plugging, atelectasis, secondary infection to pneumonias, or even viral infections. And then your mucociliary clearance, that's that mechanism that helps you to ensure that things stay wide open and smooth in your lungs. All of that is impacted. Those cells are very, very susceptible to oxygen. And then it also impacts the bactericidal for the patient. And then we need to make a very clear and measured decision about how much oxygen the patient needs and how long the patient should be on that oxygen. Let's continue. Some of the other things that we can see, we see this absorptive atelectasis. So the alveoli, you know, they're at the very end of our respiratory tree where a lot of the gas and methane is happening. And usually there's a bit of nitrogen in them. But when we start to give supplemental oxygen, particularly at high FiO2s, we end up washing that nitrogen out of the alveoli and filling it with oxygen instead. When we do that, actually, the oxygen then eventually diffuses into the tissue. And because there's no gas in the alveoli, they collapse. And this is what we call this absorptive atelectasis. And then, of course, as you start to have that atelectasis progress, you actually then have a reversal of whatever gain you've made with your oxygenation, because now your alveoli, which are the points where you really want to optimize gas exchange, are collapsing as a result of this process, which is why sometimes we really need to start thinking about positive pressure ventilation and PEEP in an effort to make sure that the alveoli stay open if we're giving high FiO2. The shunting that results is actually not corrected when you just decrease the FiO2. So it's not a rapid turn on and turn off. By the time you're sustaining this damage, just decreasing the oxygen doesn't fix the problem. So it's really important that from the beginning, you decrease the FiO2 if you don't need it to be so high, and you decrease the duration of oxygen therapy that you're giving if that is possible. What are some of the others that we might see? Accentuation of hypercapnia. This is particularly important in our COPD patients who are using the CO2 as their respiratory drive. When we give so much oxygen, sometimes the brain is fooled into thinking that ventilation is adequate. And so these patients just stop taking breaths at the same rate that they would normally do. You remember that they are chronically ill and have sort of come to an equilibrium with their respiratory dynamics. We can then give them this oxygen and actually really skew all of the processes that have sort of kept them going. And so now CO2 builds and these patients become confused, they become obtunded. And so in COPD particularly, That's the teaching. That's why we're taught, you really have to be very careful with oxygen because it can do more harm than good. Then there's the physical injury to the airway from oxygen therapy. So there's substernal heaviness, the pleuritic chest pain, cough, and dyspnea. These symptoms can be mistaken for pneumonia, for pulmonary embolus, for myocardial infarction. So you also have to think about the fact that for patients on high oxygen therapy, a therapy might actually be causing some of these symptoms as well. In children, particularly the neonates, we have bronchopulmonary dysplasia. These are young, delicate lungs that are now being subjected to toxic high levels of oxygen, does cause long-term respiratory distress, and they may need prolonged oxygen therapy for many years. Parenchymal injury. So if, there's actually the physical injury that might happen when we are actually giving oxygen as well, just from the mechanics of delivering it. Worsening of acute respiratory syndrome due to development of ventilator-associated pneumonia. So we may have ventilator-induced lung injury, and of course the diffuse alveolar damage that I mentioned. All of these things are just from the barotrauma of delivering oxygen with positive pressure from ventilators or non-invasive systems. We also have the extrapulmonary toxicity that might happen. So in addition to the toxicity that may happen in the lungs itself, we will also see toxicity to the cardiovascular system. We'll see coronary vasoconstriction and then microscopic foci of myocardial necrosis. The high levels of oxygen actually cause myocytes to die. And so oxygen has pretty significant toxic side effects. We can't always avoid them, but we should definitely think about balancing the risks and the benefits every time we start patients on this sort of therapy. Bottom line, give oxygen if you need to, but titrate it down as soon as possible to prevent development of deleterious effects, which can reverse the gains you make in the long term and make it really difficult for the patient to be weaned off oxygen therapy in the long term. So really, it's not appropriate to just put people on oxygen at 100% and then just leave them there. You really want to make sure that you are thinking through this and ensuring that you are using the right oxygen at the right time. So let's swiftly switch gears to the next topic. We're talking now about ABG interpretation. It's a necessary skill for all physicians, but particularly for emergency and critical care physicians. And I just wanted to go over this table quickly because it's shocking to me that sometimes I ask and people are giving me ABG results. I don't even know what the normal should be. So the pH on an arterial blood gas should be 7.35 to 7.45. And the PCO2 should be 35 to 44 millimeters of mercury. The bicarb should be about 22 to 28, and the PO2 is about 80 to 100. I have as a comparison to this side of it, venous blood gases, which we get a lot of times, either by mistake or because we actually intended to get a venous blood gas. And you can see that actually the values are not that different for the pH and the bicarb. The problem with the venous blood gas comes from when you're trying to estimate the PO2. So if you really have a patient where you really need to know what the oxygen tension is, then the venous blood gas is not appropriate. But for your septic patients where you want to get a lactate measurement and it comes with your gas, you just want to get a sense of what the pH might be, that's fine. If you really want to start to wean people off the vent and manage their oxygenation and their respiratory dynamics, at that point, you really do need an ABG. And so that's why we continue to emphasize that we really need to get that to do adequate management of our patients. So I'll just let you see this for a minute. I'm going to take 10 seconds and pause so people can just absorb these values because we're going to need them for the next phase of our discussion. Okay, moving right along. So I have 6 steps I use in ABG interpretation, and I want to give credit to the Thoracic Organization. I got this off of their website. I have this reference included at the end They actually have a pretty fantastic website where they have virtual critical care grounds. It's the American Thoracic Society, actually, I'm sorry. And they have a clinical education portal that also includes a guide to ABG interpretation. And so that's where I got this. That's what I'm using today. I really love it. I think it's a very nice stepwise progression through ABG analysis, and it makes a lot of sense. And, you know, it's something where we all think it's really difficult, but actually, if you just follow the steps, it's fairly easy to interpret the ABG. You just have to do it the same way each time. So we're going to go through them. The first one is that you actually have to assess the internal consistency of the values you're getting. So first of all, you need to figure out if your machine is well calibrated, because the gas that you're getting may not even be the right value for the patient. And that's done with the Henderson-Hasselbalch equation. I have some cases coming up after this that we can use to practice. And this is actually the step I usually just skip. But really, as a purist, what you should be doing is, first of all, assessing that your ABG has internal consistency before you can go ahead to interpret the results at all. Then the next step is to figure out if there's alkalemia or acidemia. We had discussed the fact that the normal pH is usually about 7.35 to 7.45. That's coming from our prior slide here. And so if it's below 7.35, acidemia is present. And if it's above 7.45, alkalemia is present. Then the next step is to figure out if the disturbance is a primary respiratory disturbance or a metabolic disturbance. And usually what you will realize is that the pH and the PCO2 are the guide to that. If it's a respiratory disturbance, the pH and the PCO2 actually change in an inverse direction. As the pH goes down, the PCO2 goes up, or as the pH goes up, the PCO2 is going down. If you see that pattern, it is actually probably a primary respiratory disorder. If that pattern is not being followed, then what you're looking at is a metabolic problem. And after you determine that, the next thing to do is to figure out if the compensation is adequate. And there are a slew of equations that you use to calculate this, which I will show you afterwards. But if you have a primary disturbance and then you calculate the compensation, and then the compensation is not what you expect, it implies that there is another secondary disorder that is also playing a part in addition to your primary disorder that is impacting the gas. If you happen to have a metabolic acidosis, step 5 and 6 only apply to that, then you would be calculating the anion gap. And if there is an anion gap, you then need to assess the delta-delta gap, which is different to assess the relationship between the increase in the anion gap and the decrease in bicarb. And this helps us to understand whether there's in fact a nuance to this metabolic acidosis that we need to understand. So I'm going to actually go through this in a little bit of detail in the following slides. So first of all, assessing internal consistency, you need to figure out, first of all, if your ABG is valid. The equation to use is the Henderson-Hasselbalch, as I indicated. The hydrogen ion concentration is actually 24 times the tension of the partial pressure of the carbon dioxide over your bicarb concentration. We usually don't have the hydrogen ions from our gas. We calculate it using this equation and then use this table on the side to determine if the pH that we're seeing is within the range of what we should be seeing for the calculated hydrogen ion. So we can calculate this using values from our ABG and then use this table to determine if the pH change that we're seeing on the ABG is appropriate. So this is the first step that you would normally take. The next step is then to figure out if you have an acidemia or alkalemia. I kind of condensed 2 and 3 together because for me, I do them at the same time. So first of all, you look at the pH and you say, it's low. Okay, I have an acidosis. And then you look at the PCO2. And as you can see from the table, if your acidosis is a respiratory acidosis, the pH is going down, but the PCO2 is going up. Examples of this would be somebody, for instance, maybe who's obtunded from some sort of intracerebral disorder, where they're not really taking good deep breaths. So the PaCO2 is rising and eventually your pH starts to drop as they become more acidotic. Your acidosis could also be metabolic. but the pH is going down and the PCL2 is actually going down as well. So in this case, the driver for your decreased pH is actually a loss of bypass. We see this a lot in a lot of our renal disorders, but there's also a lot of other disorders, mud piles, which is something we'll review later. It's a classic acronym we've all learned in medical school about some causes of anion gap metabolic acidosis. If the alkalosis is respiratory, you have the pH going up, but the PaCO2 is going down. So hyperventilatory states, excitement, fear, anxiety are all cases where you could say respiratory alkalosis. Pregnant women are at baseline as respiratory alkalosis because they're hyperventilating. We can see this in hyperthyroidism as well. And then in an alkalosis that is metabolic, the pH is going upward, so is the PaCO2. And so this is sort of what you would do. You would figure out if your gas is internally consistent, if it's an acidemia or not, and then you'd have to figure out your primary disorder, whether it was respiratory or metabolic, and then sort of go from there. Next thing would be then to determine, okay, if you figured out what the primary disorder is, we want to figure out what the compensation is. And we have all of these formulas on the side to help us do that. It's impossible in my view to remember them, but I simply pull this up when I need to, and I calculate out the compensation and determine if the compensation is adequate. If it is not, then you have more than one acid-base disorder playing a role in the patient. And so I'll just give you a moment to sort of look at this slide, reflect on the different equations. Please note that particularly for the respiratory disorders, there is a different formula if you're dealing with an acute problem versus a chronic problem, which is 3 to 5 days. So when you have patients who've been on the ventilator for a while, when you're trying to then interpret their gases, at that point, they've transitioned into chronic disorders, and you should really be using the chronic formulas. A lot of people will ask, well, how do I know which formula to use, chronic or acute? To which I'll say that's really where the clinical picture comes into play. It's impossible for me to know that just from this course, but if you have a patient who you know has been on the ventilator for 2 weeks, clearly they have a chronic problem, and you'll be using the chronic compensation formulas. If this is something that somebody is giving you a really good story for something that just started in the last 10 minutes, still very much an acute disorder, and so you would use the acute formulas instead. So moving right along for step 5, if you end up finding out that the patient has an anion gap metabolic acidosis, then you would have to calculate, sorry, if you found out that the patient had a metabolic acidosis, you then have to calculate the anion, figure out if this is an anion gap metabolic acidosis. And so the way to calculate the anion gap is actually to use this formula where the concentration of sodium is subtracted from the result of the chloride plus the bicarb. So sodium minus, in parentheses, chloride plus bicarb, and then -2 plus or -2 is the formula. And you're expecting something around 12. You have to also realize that the anion gap is usually lower for patients who are hypoalbuminemic. For every gram per deciliter decrease in the albumin, you actually have about a 2.5 milliequivalents per liter decrease in the anion gap. Please correct the values I'm telling you for whatever nomenclature you use in your hospital. Not all of the values in your labs might be milliequivalents per liter or gram per deciliter. So just make sure that you correct these values for the units that are being used in your lab. And so if a patient has hypoalbuminemia, we do have to take that into account when we correct or calculate the anion gap. And if the anion gap is elevated, then you need to consider whether or not there is an osmolar gap as well. So if the anion gap is elevated, but you can't explain it by the usual mud pile suspects of, methanol or uremia, diabetic ketoacidosis, paraldehyde, or paracetamol, INH, lactic acidosis, ethanol, ethylene glycol, salicylates, none of those things are giving you a picture for why this anion gap might be elevated, you need to start thinking about something else. And that's where the osmolar gap comes into play. You take your measured osmolality, you have to send to the lab for that, the serum osmolality. That value, you take this out, 2 of the sodium concentration minus glucose over 18 minus ketoacidosis, paraldehyde, or paracetamol, INH, lactic acidosis, ethanol, ethylene glycol, salicylates. None of those things are giving you a picture for why this anion gap might be elevated. You need to start thinking about something else. And that's where the osmolar gap comes into play. You take your measured osmolality, you have to send to the lab for that, the serum osmolality. That value, you take this out, 2 of the sodium concentration minus glucose over 18 minus BUN over 2.8. This is a very classic thing that always comes up on the emergency medicine board review banks. And if this is actually less than 10, then it's fine. But if it's greater than 10, then you actually have to start thinking about another reason why your anion gap may be elevated, that is an unmeasured anion that you are not seeing. So then once you realize that it's increased, you then have to assess the relationship between the increase in the anion gap and the decrease in your bicarb, and that's what we call the delta-delta gap. So the difference in the anion gap, the change over the difference in the bicarb. And the ratio should actually be between 1 and 2. If it's just uncomplicated anion gap metabolic acidosis, easy explanation. If it's less than 1, you need to think about the fact that there might also be a non-anion gap metabolic acidosis present. So step 6 actually helps you to realize that you may have a primary disorder, a secondary disorder like the metabolic acidosis, or the metabolic acidosis may be the primary disorder. And then you may actually have another disorder that comes into play when you are doing these calculations. You may have a concurrent non-anion gap metabolic acidosis present. Or if the delta-delta gap is greater than 2, you may also have a concurrent metabolic alkalosis present as well. By the time you're getting to this, you need a chemistry. So remember that these are not typically values you're getting off of the gaps. So when you end up realizing you have a metabolic acidosis, you actually need to go and get a chemistry so that you can have a sodium chloride and bicarb value. I typically don't tend to use the values that come off of the gas because the ABG machines do a lot of calculated. They are not measuring directly. So when I want to do an anion gap calculation, I tend to actually get a proper chemistry from the lab. I don't tend to use the values that are coming off of my ABG machine. For that, I'm talking about the ones we see here, the iStats or the GEM 3500. I tend to basically ask for a proper chemistry from the lab. I don't usually use the chemistry panel that comes from our point of care tests. Okay, so just going through this again, I'm just going to keep hammering this home because I really want people to understand it. You know, when you have a metabolic acidosis, the pH is going down. The PCO2 is the primary problem. It's also going down. And because it's a metabolic acidosis, the PCO2 are changing in the same direction. So the PCO2 is also going down. Everything goes down in the same direction. And the opposite happens in a metabolic alkalosis. But in a respiratory acidosis, remember we said the change in the pH and the PCO2 are inverted. So the pH is going down, the PCO2 is going up. Your bicarb is actually going up as well. That's your compensation. And the opposite is going to happen in your respiratory alkalosis. So what you will notice here is that the bicarb and the PaCO2 always seem to change in the same direction. It's the pH that changes depending on whether you have a metabolic or respiratory disorder. Is that clear? Just take a moment to take in this chart. It's vitally important, especially when you're at that point where you're trying to understand the primary disorder that is causing the issue. Okay, let's go into some cases. I really like to do these, really practicalize it and bring it home and make sure that we really understand what we are doing. So case one, we have Mrs. Fumi. She's a 60-year-old woman with pneumonia, has baseline hypertension, and was admitted with dyspnea, fever, and chills. Maybe she had pneumonia. So we're expecting, that first type of hypoxia, the hypoxic hypoxia, because she'll have a diffusion defect from her pneumonia. So when we look at the gas we get from her, the pH is 7.28, the PCO2 is 56, the PO2 is 70, the bicarb is 25, and then our pulse oximeter is showing us a saturation of 89%. A word on the pulse oximeters, we are dealing in Africa, and you do need to be very cognizant of the fact that there are some minor changes to the values of the pulse oximeter. It may not be as accurate in dark-skinned people. And so it's still a valuable tool for us to use, but you should be aware that sometimes the pulse oximeter works by detecting the wavelength that's reflected off of the hemoglobin passing under the probe. And sometimes it just has trouble doing that for darker skinned people. Like most things in the world, it's been calibrated for Caucasians. And so you may find yourself with some really funny values. And you should just be cognizant of the fact that it's the possibility with your patients. Going right back into this case. So the first thing is to determine the internal consistency of the gas. Should we even believe these values? So we say then it's the formula, the Henderson-Hasselbalch equation is 24 times the PaCO2 over the bicarb concentration. And so when we do that, I'm going to bring my calculator out. We have 24 times the PCO2, which is 56 in this case. And then when we divide that by the bicarb, we get a hydrogen ion concentration of 53.8, thereabouts. Let's go to our table from the Thoracic Society. If we have a pH of about 53.8, then that means we are expecting a pH that should fall somewhere between 7.25 and 7.30. Let's go back to Mrs. Fumi's case. The pH indeed does fall in that range, so we can believe these gas results, they seem to be internally consistent. We may proceed with interpreting this ABG. All right, so the normal pH is between 7.35 and 7.45. And we now have a pH of 7.28. So clearly this is an acidemia. The next thing we need to figure out is what's the primary disorder? Is it a respiratory acidosis or is it a metabolic acidosis? So we know our PaCO2 value should be between 35 and 45. And our normal bicarb value should be between 22 and 28. Bicarb seems normal, so it hasn't changed, but the PCO2 has risen. So we have a pH that's going down and a PCO2 that's going up, which is an inverse relationship indicating that the primary disorder here is probably a respiratory acidosis. So we've established that. The next thing we have to do, step 4, is to figure out if the compensation is adequate. So for that, we have to go to our tables here and look for the formula for respiratory acidosis. And the formula there says that we are expecting the change in the PaCO2 over 10 to be, that's the increase in the bicarb that we expect. And we have a plus or minus correction factor of 3. Before we even do this, we even already know that this compensation is not there, because we already know even that our bicarb hasn't increased at all, right? But if we go through the exercise of calculating this out, If we assume that a normal PaCO2 is 35 and we have 56 now, bringing out our handy calculator, 56 minus 35 comes out to 21. And if we divide that by 10, we have a value of 2.1. Plus or minus 3, if we subtract 3, we go down to 0.9, negative 0.9. If we add 3, we go up to 5.1. So we would have a change in our bicarb rate that would go anywhere from 21.1 to 27.1. Those would be the changes in the bicarb tolerate if we assumed a normal value of 22. And so we're not seeing that here. So in summary, what we can say is that this person has an uncompensated respiratory acidosis. The Henderson-Hasselbalch equation tells us that this is an internally consistent gas. We have a pH that indicates acidemia, and the pH and PaCO2 that indicate that we have a primary respiratory acidosis. When we try to correct, we see that we don't actually have any kind of change in the bicarb. So there has been no compensation so far. So this is an uncompensated respiratory acidosis. And steps 5 and 6 would not apply because we are not dealing with a metabolic acidosis. So we would stop there. Very simple. I mean, the American Thoracic Society has made it idiot-proof, in my opinion. The next case that we would go over is Mr. Chukwuma, who is a 77-year-old retired soldier. For me, whenever we see these types of things in cases, they're never put there just for show. When I think retired soldier, I'm thinking somebody who's doing a lot of smoking while he's waiting for some action. Maybe he's had some exposures to some toxic gases during combat. So they're giving you a sense that this man might have some baseline COPD or respiratory disorders. Anyway, he's coming in this time for urosepsis. So all of that is irrelevant. It's just a red herring. And over the last 2 hours, he's developed shortness of breath. He's becoming more confused. And they're giving us the ABG results below. pH is 7.02, PaCO2 is 55, PO2 is 77, bicarb is 14, and his saturation is 89%. So before we even do anything, of course, we've got to do our Henderson-Hasselbalch, make sure that this gas is actually even internally consistent. So if we take 24 times that PaCO2 of 55 and divide it by a bicarb of 14, we get an hydrogen ion concentration that should be somewhere between around 94.3. When we go to our table, hydrogen ion concentration of 94.3 falls somewhere between 7.0 and 7.05. So we go back to Mr. Chukwuma and we see that his pH is 7.02. So this gas is okay. Next step then is to determine, is he acidemic or is there an alkalemia going on? Well, the normal pH is 7.35, so 7.02 is clearly lower, which indicates that this is an acidemia. Okay, very well. Are we having a respiratory or are we having a metabolic? pH has gone down, but PaCO2 seems to have risen. And bicarb has also gone down. So we have pH going up, pH going down, PaCO2 going up, and bicarb going down. Let's go back to this. Doesn't seem to be following any of the patterns we expect because we say the PaCO2 and the bicarb usually tend to change in the same direction, regardless of the problem. So there's clearly more than one thing going on here. You can already tell. If we go back to our problem with the pH going down and PaCO2 going up, we'll start with a primary respiratory acidosis as our problem. Then we need to figure out what our compensation is. So we have said that the change in the increase in the bicarb should actually be covered by the change in the PaCO2 times 10. That's from our compensation formula here. Our change in the PaCO2 to 55 gives us a change of about 20. If we divide that by 10, it's 2. And with plus or minus 3, we can expect an increase of -1 to about 5. And we know the normal value of bicarb is 22. So we should see an increase to at least 24, if not 27, or we go down to about 21. So let's look at what our bicarb is doing here. Our bicarb is even lower. So the compensation here is not what we would expect. So now we have a lowered bicarb as well, which is probably contributed to the acidemia. So this indicates to us that we have a primary respiratory acidosis, but we probably also have a metabolic acidosis as well. Because remember, with the metabolic acidosis, your bicarb decreases. The decrease in the bicarb is really drastic, and we have a lower pH. So we can have a mixed disorder here, where we actually don't have, sorry, I kind of closed out of my PowerPoint. We have a respiratory acidosis, and then we actually also have a metabolic acidosis as well. So it's a mixed picture. Now, if we wanted to go on with the metabolic acidosis, we'd actually need the chemistry to calculate out the anion gap and possibly the osmolar gap. We don't have it, I'll leave it here, but this is just to show you kind of how we should be thinking about these disorders. We may be seeming to go quite fast, but I assure you that if you take this steps and you practice them with all of the gases that you're seeing, you're really going to see an improvement in your ability to interpret them. So just do them each time until you get very facile with thinking through how to interpret ABGs. I have a third case, Mr. Nuru. He was admitted for a drug overdose. Typically when I'm saying that.
Okay, everyone, so I'm going to stop there actually because we've gone over the hour. Can I take any questions that might have come up now? ABG analysis is quite, is very common. And I think in the beginning, people might find it slightly challenging, but the key to this, which I find very helpful, is that everything has a formula and you just have to follow the steps. So once you follow the steps, you just go through the analysis. And sometimes, of course, it's still challenging because you might have mixed pictures, like a mixed respiratory and metabolic or something like that. But for the most part, the rules that were presented in the lecture will help you to analyze and understand 80 to 90% of the ABGs that you see. And then, of course, there's a very small ratio of them where you will need a nephrologist or someone really expert to assist you. I know that I don't know if Dr. Jifini was still on the lecture, but we do have some of our other senior docs on the call. Folks can chime in about their own experience with this and any tips they have for analyzing ABGs. We do have a lot of younger staff on the call, and just help them to kind of think about the ways in which you go through analyzing ABGs. I always love to hear from other people about maybe some tips they have for how to do this. And then, of course, I want to thank everybody for listening in. So I don't know if there's anyone who also has some comments that they can share. Dr. Ojifin might have dropped off.
Okay, thank you, Dr. Fashino, for the lecture. I hope we're going to have a part 2 to continue continuing, because I have some questions on how is it the same interpretation for ventilated patients? Because I noticed that in the shift in the ICU that I did, some of the ventilated patients were having like their PO2 like 160 and thereabout, and we were kind of adjusting the vent setting based on their ABG. So I just wanted to know, like, is it a bit different when you're looking at ventilated patients, the interpretation, or is it still pretty much the same?
So the rules still apply, but what you have to do in vented patients is remember that you're giving supplemental oxygen. When we're doing ABGs in the ICU as we're managing ventilated patients, usually we might have already done the initial ABG that establishes what the primary insult is. And unless there's something new, like ongoing renal failure or ongoing respiratory issues, most of those routine ABGs are really being used to monitor the vent settings and our capacity to wean. So what we're really chasing most of those times on those daily ABGs is the PO2 to make sure that we are not exceeding the normal values. And I just told you that the normal PO2 is 80 to 100%. Even if you are being ventilated with supplemental oxygen, we still want to keep the PO2 in that range. And I've told you that oxygen is a drug. And so if you have a vented patient with a PO2 of 160, that means that whatever FiO2 you're delivering needs to be dialed down.
Okay.
So that's really how they help you. But the same rules apply in terms of interpreting the gas. You just have to remember that by the time you are working with an ICU patient, you might already be interpreting a gas that is displaying some compensation.
Okay.
Any other questions? Everything was very clear. All right. Well, the recording is available online. Thanks for joining. We're very happy to take questions after. You can forward them on to me directly or to the admin, and she can forward them on. And I just hope this will really help folks as they're managing people in the emergency department and in the ICUs moving forward. So thanks everybody, and have a very wonderful and pleasant day.